for Academic Half Day. I would love to turn the virtual podium over this morning to Katrina Sullivan. Thank you so much for being here with us this morning, and we'll go ahead and get started.
Oh, Courtney, thank you so much. I'd like to take just a minute to introduce myself. I'm Katrina Sullivan. I'm one of the podiatrists at Harborview, and I have clinic sites both tucked in with the adult medicine clinic as well as Pioneer Square, and I do cover some remote sites as part of the healthcare for the homeless. And thanks to John for inviting me to come and chat about foot issues that come up in patients with diabetes. So I have no disclosures when we'll get started. We did build in some time for questions, and our wonderful support people are going to help monitor the chat box if there's some questions that come up during the talk. So let's go. Learning objectives today, we're going to just review the diabetic foot exam, performing it and charting it, evaluating a diabetic foot ulcer. If you have a patient that comes into clinic with a foot ulcer, what do you do? Besides just call a podiatrist. We're going to also review how to diagnose and initiate treatment on a Charcot foot, and we're going to cover some treatments for ingrown toenails. So not all ingrown toenails are the same. Let's get started. Our first case is a follow-up visit. And when your patients come back, is a 48-year-old male with hypertension and diabetes. The electronic medical record is giving you a reminder that the patient is due for the diabetic foot exam. The patient wonders if he can get free shoes. He heard that diabetic patients can get shoes. The main components of a diabetic foot exam are going to be visual inspection, and you're going to try to identify patients with foot deformities. You're going to look for skin integrity or loss of skin integrity. You're going to want to know, can you palpate a pulse? It's not the full vascular exam. It's just, can you easily palpate the dorsalis pedis and the posterior tib pulse? And is this part of the exam different from your prior recorded exams? And that will matter if the patient is developing a foot ulcer or new problems. And we'll go over the monofilament exam. And the monofilament exam can be quite streamlined, and we'll talk about that in a minute. So this is a good example of a foot deformity. So the big toe, the great toe, is bullying and pushing the second toe up out of the way. There is a bunion bump, which is from the hallux valgus, which is the angulation deformity. This is a hammer toe. You can see a little red spot on the top of the hammer toe, and this would leave a patient vulnerable for developing pressure sores from shoe gear, both at the bunion bump and from the hammer toe itself, as well as some pressure areas on the ball of the foot. You do want to look between the toes when you're doing your visual inspection. So this is a good example of tinea pedis. It is interdigital. You would not necessarily find that if you didn't physically part the toes. So do remember to do that, because our patients sometimes don't see their feet real well. They have a hard time getting all the way down there to take a look. And this is a good opportunity to do some patient education about drying, washing the feet, drying carefully between the toes, and using some topical antifungal to help that clear up. This is not a particularly clear slide. However, if you just follow, there's a little bit of a skin change. There's some roughness and dryness to the skin, a little bit of some red speckling, and it's in almost in a moccasin distribution, as if the person was wearing a moccasin. So this actually represents moccasin foot tinea pedis. And this would respond quite well to some topical antifungals that can be applied every single day, whether they're in the bath or shower or not. Some of my homeless patients will present with this. They don't necessarily have access to clean running water every single day, but I do encourage them to get the topical antifungal cream on each day to help this improve. Some people just think this is dry skin. They'll keep putting moisturizer on without much change, but this is actually tinea. When we're doing our visual inspection, we need to look at their shoe gear, not just their feet. This is from a patient who is a busker at Pike Place Market when they were still able to perform down there. His brakes didn't work very well on his bike that he used to get from where he was staying down to where he performed. So he would drag a foot on some of the downhill sections to slow the bike down. He did present with a skin ulceration in that corresponding area. So when you do see an abnormality on a patient's foot, do take 1 minute and look at the shoes, not just the tops of the shoes, but turn the shoe over and see if that could be a contributing factor. This is an example of a diabetic shoe. A couple salient points is that the toe box is very, very deep. So that will accommodate things like those bunions and hammer toes we saw earlier. Some of the diabetic shoes will have Velcro closures for people who are developing some arthritis in their hands and perhaps are having difficulty tying shoelaces. It's also nice to have Velcro closures if people have difficulty reaching their feet. That way they don't have to be doubled over quite so long, getting short of breath while they're trying to tie up their shoes. There's a hint of pink in there, and that's a multi-layer insole, which is often placed in the diabetic shoes for pressure relieving purposes. And the collar around the heel and ankles of the shoes is very, very soft and forgiving. When we're trying to palpate pulses, the dorsalis pedis, you'll find it has a normal course in 85% of the US population. So if you have an otherwise well-perfused foot, you can find the posterior tib easily, and you're just searching, using all your good landmarks for your dorsalis pedis. I wouldn't sweat that. If you have found the dorsalis pedis artery easily on your prior exams and you can't find it today and there's a new problem, that would get my attention. So good landmarks are going to be the anterior tibialis tendon. If all of you just sort of pull your foot up towards your shin, a lot of you can either easily feel the anterior tib tendon that will fire, a nice strong tendon there. A lot of people it's actually visible. If you pull your lesser digits, the toes 2 through 5 up, that will fire the long extensor to the toes, your extensor digitorum longus, and that makes a triangle. If you look inside that triangle, most of the time you will find the dorsalis pedis. Posterior tib, you're going to want to use the sort of distal-most aspect of the malleolus, and you can wrap 4 fingers. So I will take my, not my thumb, but my 4 fingers, use the bottom of the malleolus, and then just sneak in behind the tibia back just above the tarsal tunnel and find your posterior tib artery. A little bit busy slide, but the salient points are for when do you want to test non-invasive testing. If you have abnormal or absent pedal pulse, if somebody's over 70, if you have a smoker 50 to 69 and a history of diabetes, you want to check your ankle brachial index. However, the ankle brachial index can be a little bit falsely elevated. So if you have an ABI above 1.3, you really are going to want to look at your Doppler waveforms and your toe pressures, which is ordered as a TBI, toe brachial index. Monofilament exam. Approach the skin perpendicular. You want to put just enough pressure to buckle the monofilament, and then you want to leave that area. And that should take about 1.4 seconds. You really do not need to test the dozen sites that are in the older literature. You can test the big toe, one of the other toes, a couple of sites across the ball of the foot. That will give you the information you need to know. By the time the numbness has reached the midfoot or the heel, it's a moot point. This is a stocking glove distribution of nerve loss or neuropathy. It's going to start at the distal toes. It's going to work proximal up the foot. So really for time's sake in a primary care setting, testing the toes and the forefoot is going to give you all the information you need to know. You want to test the intended site once. If you come at an angle and the monofilament skips, you want to just go to your next site that you intended to test and maybe return to that prior site. But if you don't want to hit the site enough times that the patient finally feels it. People want to be right when they're doing the test. So sometimes we'll peek and cheat, and we're not testing their eyes, we're trying to test their nerves. So if someone's anxious, I'll show them on the back of their hand. It's a tickle test. I don't tell them I'm going to poke them because that conjures up thoughts of needles. And if they're really anxious, I may test their shin where I suspect they will feel it. And then they're like, oh, eureka, I got it right. And then I'll move on to the foot where I'm more interested. Once we've done our monofilament testing, we stratify as far as risk category goes. And the low risk people have preserved their protective sensation. So that's going to be risk category 0. On our high-risk individuals who have lost their protective sensation, we can stratify them further. So they have lost their protective sensation. So category 1 would be lost protective sensation, no deformity, so no bunions, no hammer toes, no unruly toenails. They've not yet had a foot ulcer, so they would be 1. So that's the lowest risk of our high-risk group. Category 2 gets a little more interesting because they've lost their protective sensation and they have a foot deformity. They have a bunion, they have a hammer toe, they have unruly toenails, things that could cause pressure on the skin and cause the skin to break down. So these are people that are at risk. These are people that we want to be steering towards resources for fitting in good shoes, perhaps a diabetic shoe, maybe steering them towards some help with some toenail care if that's not something they can manage at home. Our category 3 are our resource-rich individuals. These are people that have developed a foot ulcer. They don't have to have a foot deformity necessarily to develop a foot ulcer, but they do, the salient part here is that they've lost their protective sensation. These are the folks that are at risk of going on and having a major lower extremity amputation. So these are the people that you want to know well. You want to make sure they're connected with the appropriate amount of resources available in your system. The big conundrum on diabetic footwear. I can't speak 100% to what the VA coverage is doing. I know in the past they have followed Medicare guidelines. I don't know where they're currently at. Medicare criteria for diabetic footwear is going to be if the patient has a history of an amputation, either partial or foot, they would be approved to have shoes for life, and it's 1 pair per 12 months. Patients that have loss of protective sensation and, so it's not just neuropathy, so it's loss of sensation, diabetes, loss of sensation, and either a foot deformity, a preulcerative callus, or a history of a foot ulcer. So when the patients come in and they say, I have diabetes, I heard I get free shoes, I go, maybe. So it's a little disappointing for some patients, but it is considered fraud if you approve diabetic shoes saying the patient meets all of their criteria if the patient does not. We want to document our exams. There's different tools, and in the UW clinics, we're using Epicare. There is a dot phrase that can help populate some charts for your charting. There is the diabetic foot screen. If you go .foot, you have choices of the diabetic foot screen or the comprehensive diabetic foot exam. The screening sounds like the one you want to take. I would steer you more towards the one that sounds scary, which is comprehensive. The screening one will drop in a big chart, and you have to F2 through all the things, lots of questions. The comprehensive just covers our 3 main questions. It has a few other questions which you're absolutely legitimate to say not done. Once you've done your visual inspection, you've checked for pulses, and you've done your monofilament. The remainder can just be, you can F2 through those quickly as not done. There are some very good prompts that are built in to guide you through that. In order for the date that you document your foot exam, you do need to do an EPIC order, and that's foot exam with monofilament in the little order box that typically is down to the lower left-hand side of our charting. That's what populates the date the foot exam was completed. That sends it to your dashboard and helps some of those colors turn from red to green. The VA Puget Sound, I was able to capture a few screenshots. I'm a little jealous. Your foot exam is quite nice. I might borrow some elements from it. My understanding on some of the workflow is that the nurse, the LPNs will help do the foot exam, and then the provider sees the results. So I can't say exactly I know that inside out, but there are some charting tools available in the EHR that the VA uses. Any questions on doing the main elements of the foot exam or how to document it?
There's a couple of questions that have come up in the chat, one of which says, if it's abnormal on one exam, do you continue to perform the exam subsequently the next few times you see the patient, or do you just now note that they have neuropathy? And then there's a couple more questions, but I'll pause to allow you to answer that one.
So the question was, if you have an abnormal finding on year 1, and then they come in for year 2, yes, you would do the exam again. They don't necessarily go down the scale. They, if they've gone from a 0 to a 1, they don't necessarily go back to a 0, but you want to see, have they progressed? Have they developed any other foot issues in that subsequent year? So the exam can get quicker and quicker. Once somebody becomes a category 3, they never go back down the scale. So It's more just taking the shoes and socks off and having a moment for patient education as you're checking. Diabetic patients, if they anticipate that the provider's going to take the shoes and socks off to do a foot exam, they'll clean their feet. They'll, just like we do when we're going to the dentist, we'll floss a little extra. So it's really a good motivator for patients, self-care. Okay, next question. That's a great question.
And then a question and a comment. I saw a patient once whose monofilament test was normal, but he had some loss of vibratory sensation on his toes unilaterally. Which is lost first, and does this patient have neuropathy?
So the patient would have neuropathy, yes. The monofilament is considered a threshold test, and neuropathy is a bit of a spectrum. So it's a bit of a bell-shaped spectrum. So when do they cross that threshold? The monofilament is validated, so it's sort of a quick tool when we're doing screening. If you have the extra time to do, the vibratory sensory, you can do hot cold, you can check reflexes, that's lovely. I just find that when we are just trying to make sure we're getting things done, that the threshold is a good tool. I think all diabetic feet are at risk. So, but I'm biased. I'm seeing the people that are in trouble. I'm not seeing the ones that are doing well. So I would still call that at risk for neuropathy and at risk for foot complications. Yes, good question.
That's all that's in the chat right now.
Okay, let's move on. Case 2. You have a return visit. You have a 65-year-old male with heart failure, chronic renal insufficiency, and diabetes. Mentions a blister on his foot. He has increased lower extremity edema from his heart and his kidneys. He's late on refilling his diuretic. A recent bump in his creatinine. Hemoglobin A1C has room for improvement. It's Friday afternoon clinic, which I think, by the way, should be abolished. My blood runs cold when a diabetic patient comes to me with a blister on a Friday afternoon. So this is the blister. A little bit difficult to tell on this photo, but right here, this is actually drainage coming out. It's serosanguinous drainage, but it is coming out of this hole where the blister used to be. This actually is one of my patients from Pioneer Square Clinic. He's a sessions musician, was working as a drummer, and they wrapped up later than he thought. He got to the bus stop at 2 a.m. The bus wasn't going to run till 5, so he decided to walk back to the shelter where he was staying, several miles, and developed a blister. Waited till his scheduled visit to come show me the blister. And this is the rest of the foot. So he has erythema, and I can tell you this is warm to touch. There is purulence under the blister that has moved from the plantar portion of the foot to the dorsum of the foot. Whenever there is a plantar skin breakdown and dorsal erythema that's ascending, that is a diabetic foot that's in trouble. So this is a patient who will need to visit with our emergency room colleagues and be admitted for care. There's 4 tissue planes, 4 distinct tissue planes in the foot. So anytime a plantar wound can cause dorsal erythema, we already know that the infection process has crossed several tissue planes. So that's a big red flag. When you have a patient with a diabetic foot ulcer and you're in clinic and you're trying to make some decisions, do I need to knee jerk and send this to the ED? Perhaps, but not always. If you're trying to say, is this something that would be safe for me to gather some information in a timely manner and make an informed clinical decision about whether we can initiate. There are some ways to go about gathering some of that information. The labs that you would want to know about, you're going to want to know what your white count. So your CBC, you're going to want to either BMP or CMP, depending on the other comorbidities. You're going to want to know some of your inflammatory markers, and you would like to take a deep culture, particularly if you could get deep tissue. And on neuropathic patients, it's a little easier to do than someone that has intact sensation. We're really discouraging people to take superficial swabs. They're just unreliable in diabetic patients. you can order stat labs and start getting your information within 45 to 60 minutes. So late Friday afternoon, that's a problem. We'll need our ER colleagues to help us determine whether this is something that's safe to send home with close follow-up or something that has to come in-house. But say it's Tuesday morning, you probably would have time to gather some stat labs and perhaps even get an x-ray. And that can help you make an informed decision about whether you can try some PO antibiotics and bring them back the next day or two to see if they're responding. If you're unable to palpate a pulse and you have a red hot swollen foot like we just saw, I would want to know, is there adequate arterial inflow? And on a diabetic patient with any other risk factors, and this person had the renal insufficiency, I would add to the ABI, the ankle brachial index, I would add the toe brachial index, and I would add a arterial Doppler. Mostly because the ABI can be falsely elevated and that give you a false sense of security that there's adequate inflow. And instead, what you were seeing were non-compressible vessels. So in many clinic settings, we can gather the labs and x-rays. If you order them stat, have the either clinic collect or have the patient go to the lab, get your stat x-ray, have the patient come back. Within an hour, you can be making an informed decision. That way, you perhaps can avoid a hospitalization if it's not necessarily, or you will have really good data in your hand saying, I need to do a direct admit from clinic, or I'm going to have to lean on my ER colleagues in order to get this patient care started. So those are some things that you can do. So it's not always a knee-jerk that everything goes to the ER, and it's not always everything goes home. But you want to develop a pathway in your clinic site that you can make the best decision possible. Bit of a busy slide. There's a couple things to appreciate here. One is when we're looking at foot infection, this is the purple at the bottom, you can have a really scary wound that's just not infected. There's no purulence, there is no erythema, there's no warmth. However, you do have mild infection if there is cellulitis that's less than 2 centimeters from the edge of the wound. You've bumped into the moderate if the cellulitis extends greater than 2 centimeters. And that's something you can use that as a clinical tool. You can use it as part of your clinical assessment, saying, I think this is a scary wound that's not infected. I think this is only mildly infected, or it's not a very scary looking wound, but the erythema is greater than 2 centimeters. This is getting ahead of us, especially on a diabetic patient. If we have a lot of tissue damage, if we have inadequate arterial inflow and we have severe infection, we start to get into this black hole. And those are the patients that don't do well. But the key point here is you can use your 2 centimeter guide as has the patient gone from mild infection to moderate infection, and you can look at that clinically. So we have the non-infected, the mild infected, the moderate. And the severe with systemic response, those are pretty easy to identify. Those are people that eyeball is sick. So, but what can be a little bit challenging is, is this mild or is this moderate? And so 2 centimeters should be a good visual guide to use. So your preliminary workup, the white count was up. He had a bump in his creatinine, the CRP, the ESR. We were able to get a bit of deep tissue, deep from the wound base, which showed gram-positive coxate. He had erosion at the 5th met head. The cellulitis was definitely more than 2 centimeters. He did have good palpable pulses. Unfortunately, this patient, though he presented with an acute osteo, he did go on to lose the whole foot. So, which then sort of opened a door to exacerbating his heart failure. And he did not live a year after that episode. But what if this was the wound? And I apologize for the blurry slide, but here's a wound along the medial first MTP. It's not really erythematous. It's not warm to touch. So this doesn't really look that bad. So would you just give them some antibiotic, or would you just do local wound care and send them home? I would still want to know a little bit more about this. This is somebody who's insensate. And I'm going to give you one little clinical hint. If you look at this digit, it looks a little fat through here to me. So when we look at this patient preliminary workup, and this is clinic-based workup, you know, the white count's a little underimpressive, the creatinine's staying, the CRP is a little underimpressive. You know, an ESR above 40 starts to get my attention in a diabetic patient. Patient has erosion of the first met head. This patient has a subacute osteomyelitis. So there's no erythema in the soft tissue, but there's very slight edema. So this is one that can fool you. So this is actually an osteo. This does not need to be admitted to the hospital in absence of a systemic response. This has been going on for a while. This is not an acute new process. This is subacute to chronic. This is where looping in our infectious disease specialists to help us design a 4 to 6 week course of antibiotic would be important. So this is something I would not necessarily go alone, but this is not something that needs to be admitted, but this is something that definitely needs care. And this is one that you could pass off as saying, oh, it's not a big deal, where there's actually some underlying bone. So that's for the X-ray is just very, very helpful. We did not need to go to MRI or CT to figure this out. We can figure this out with just a plain film. Questions? So just trying to help you appreciate that some of the workup can be initiated in clinic, and then how it gives you some framework on how you would go about that. This is also a point where John requested just a little mini session on dressing. Say we were looking at this wound, and we know we're going to loop in our infectious disease specialist to help us design a prolonged course of PO antibiotics. This is a patient that I would consider putting on a dressing that could stay in place several days at a time. This does not look like a highly exudative wound. This would be somebody that we could consider using one of our dressings. At the Harborview sites, we happen to use a product called Mepilex, and that's a foam dressing that has the tape border already on it. Mepilex, which is just a brand name, so it's just a brand name for foam dressing. It also comes without the taped on border, so the Mepilex, you can trim this to be just slightly larger than the wound and then secure it gently with some specialized tape that's very kind to the skin. This wound would be a good choice for using one of the wound healing gels. This happens to be a product called Medical Honey. It comes in a tube, and we would send that home with the patient with the instruction to use soap and water to wash the wound, apply a thin layer of the wound gel, and then cover it with one of the foam dressings. And then this can stay in place for 2 to 3 days at a time, or until they have too much strike through. But this is not a highly exudative wound, so that would be fair to do. If we had a prior wound, the wound that with the big red hot swollen foot, I would be cautious about placing tape on skin that has active cellulitis, because that skin is very fragile and the skin layers could separate. So then you're going to have 2 wounds to manage instead of the 1. So the red hot swollen foot that was actively draining, that might be where you want to use an alginate product. The brand name that we happen to have at Harborview is called Caltastat. It's basically just a fibrous material made out of seaweed, and patients love hearing about that part. And that is very absorptive. You can even accordion this to be several layers thick, particularly since I saw fluid dripping out of that patient's foot. You can cover that with just a simple gauze square. I would put a gauze roll around that and then tape to the gauze roll rather than tape to that skin that has active cellulitis. Because when the skin is that inflamed, the skin layers will separate very easy. They go to do the dressing change, or the nurse goes to do the dressing change, and now we have skin that has lifted off. So there's a second wound. So be a little cautious about putting tape directly on very inflamed skin, because the layers are very weak. So
Katrina, there's a few questions that have come up in the chat. I'm going to do my best to try to consolidate the questions because I think a lot are hitting on similar topics. I think traditional teaching is that often there's concern and we might need to order imaging for these patients. When might you be thinking about an x-ray versus an MRI? And sometimes we can be fooled by if the x-ray doesn't show anything, how can we be certain that osteomyelitis is not present for these patients? And then there's a couple more that have come, but maybe if you could comment on that.
Yeah, let's touch base on the imaging question. That's correct that the plain film will have about a 2-week lag behind the bone changes. So you may see very elevated inflammatory markers, a significant white count, and you get the baseline x-ray and the x-ray looks normal. That patient, if they're not systemically sick and you're going to choose some outpatient care, you're going to be following them very closely. See them back in the first few days to see if they're responding to the antibiotic you chose, see if the swelling is starting to reduce on the foot. If the foot is not responding, you can get your follow-up x-ray. These are people that are not having a florid, they're not sick. These are not the people that need to be admitted, but the people you're going to follow as an outpatient. You can track an x-ray. I would not take an x-ray before the 2-week mark from your baseline film, because you just won't see changes fast enough. But if you have a wound that is slowly responding, the foot is looking a little bit persistently swollen, even as the erythema is reducing, I would do a follow-up film. You don't always need to go to the more expensive tests if you're getting the clinical response you're looking for. I do like to start with a plain film because if I find changes, bone changes on plain film, I don't need an MRI to tell me the bone is involved. So that missing bone changes on an early x-ray, if the patient is responding clinically to the treatment, they weren't septic in clinic, septic appearing, you're safe to start with the plain film. You don't have to jump. Now, if you're admitting somebody and you're having difficulty getting source control, that's where the MRI can really help you say, we're not getting source control because the infection has already reached the bone, even though the x-ray did not tell us that there was significant bone change. And that's where our surgical colleagues can come in and help us get source control. So it's tempting to want to go to MRI and CT early on. In a diabetic foot, we don't always need to. We can learn a lot from plain films. And in clinic, I find, because I can get a plain film in real time, I can, 45 minutes, I can have an answer on a plain film. You know, I can look at the image and say, yes, I'm suspicious, or no, I think we're still safe. So don't, I think x-rays are underutilized. There's a lot of patients are admitted with diabetic foot infections with ascending cellulitis. A lot of good lab workup, the MRI is ordered, and a plain film was never ordered. Yeah, the MRI showed osteo, but so did the plain film. So we don't always have to go straight to MRI. Good question, though. Really good question.
And then another question, say you're seeing a patient whose exam, looks similar to this picture, but maybe they're immunocompromised and therefore might have some inherent inability to mount a large inflammatory response, therefore less purulence, not have a fever like a non-immunocompromised patient might. Where is your level of suspicion where you might jump to doing labs and imaging earlier for patients? Any comment on that?
So that's a great question, because inflammatory block is a very real thing. You can have inflammatory block just from poorly controlled diabetes. It doesn't have to be other reasons for the patient to be immune compromised. When I see a wound like this, I check lab and x-rays. I just have a really high index of suspicion. Labs and x-rays are fairly inexpensive tests for the amount of information you can learn. And in this case, I learned that there's a mixed picture on the inflammatory response, but there's already x-ray changes. So this was something that if we didn't check the x-ray, we would have passed off and just gone on with wound care with nursing help us and been disappointed with the results because the problem really had already reached the bone. So I have a very low index of suspicion. I have a high index of suspicion. I have a low threshold. So I order a fair amount of X-rays on wounds that are not doing what I think they should do. So good questions.
And then this last question, I'll smush a couple of things together, and you might be getting to this in the presentation. But at what point might there be a role for taking a deep wound sample or a bone biopsy, and then in treatment of a chronic osteo or an acute, any comment on the duration of antibiotics, when you might be getting the surgical colleagues involved?
Great questions. Our ID colleagues love bone biopsies and deep tissue. They are very disappointed if we only offer them a superficial swab. The joke is with a diabetic foot wound, you can swab the floor and swab the wound and get the same result. So they really discourage swabs. But so anytime that a deep swab, you can probe, when you're trying to probe to bone, you can do it with your culture tip. And if you, and you can send that as a deep culture. You can often go in and grab a little bit of deep tissue because the patients are frequently neuropathic. So they tolerate those deep tissue collections quite well. If you have access to a bone biopsy, you know, that's ideal. A true clean bone biopsy, the skin is prepped and you go after the suspect part of the bone through intact skin rather than through the wound itself, because that can contaminate your bone biopsy if you're going through infected soft tissue. But bone biopsies and deep cultures are going to be your ideal pieces of information for directing longer term antibiotic coverage. You can do a surgical consult if you're having trouble with source control, but you know, in an example what's on the screen, it's our ID colleagues that are going to really help us make a plan. And 6 weeks is pretty common for trying to treat, for primary treatment of known osteomyelitis. Often ID will say they will treat it for 6 weeks. Whatever improvement we're going to get. And then if they're not seeing significant progression of bone loss, then they will call it good. And they say they will only treat flares as the flares come up rather than continuing to treat it till wound closure. So, and the flares would be a new onset cellulitis because of the open wound and a secondary bacteria moved in. So that can be disappointing for patients who feel like, oh, my wound is still open, I need additional antibiotics. You stopped the antibiotics too soon. But we weren't treating the skin wound, we were treating the underlying bone. I have quite a few patients that have abnormal looking x-rays from prior osteomyelitis. The osteomyelitis did not magically resolve, it just became quiescent. And I really try to educate patients that the reason we do the longer antibiotic course, the 6 weeks, is we're trying to get the body to wall off the problem. We know it's there, it doesn't go away, it just goes in hiding. Now, the downside to that is that osteo can be reactivated in the future. As I always caution patients that, you know, the wound closed, the foot stabilized, the bones x-ray stabilized, they finish the antibiotic course. I always tell them if any redness or swelling, change in shape, or just the skin breaks open and it starts draining again, that's a sign that the osteo has reactivated and we will need to revisit some other treatment options. And often at that point, that's where we have to have a serious talk about taking away bone.
And then the last question, just jumping back to imaging, say this patient had a negative x-ray and it has maybe an equivocal exam. Is that when you might reach for the MRI if the x-ray was negative, or is it something that you would just follow clinically?
If I saw this wound and the x-ray was normal, I'm still a little suspicious, just the physical look, and that's just from looking at hundreds of feet for years. I would have close follow-up and I would consider repeating the x-ray depending on how the wound responded. If the patient came back in 2 weeks and the wound was a tenth of this size, then I would be happy and just continue to follow clinically. But if they came back in 2 weeks and the foot looked exactly the same, the wound was the same, the little bit of thickness through the big toe was still present, I would repeat the x-ray. I am slower from an outpatient side. In a non-sick patient, I'm a little slower to go to MRI because I can often learn what I need to learn with x-ray. When we get these MRIs and it shows early osteo, there's bone marrow edema, we're still going to follow the patient's clinical response to the treatment. If they're inpatient and they're on IV antibiotics and there's not a significant amount of bone loss, but there's bone marrow edema on the MRI, we're still going to follow the clinical response to treatment. So they're not necessarily going to go to the OR, and they probably won't go to the OR that inpatient admit unless they're really, really sick and we can't get source control. So having this MRI result out there doesn't necessarily change how our approach to treating that patient at that time. And that's a little bit why I don't necessarily go to the MRI so quick. If I have a really sick patient and we can't get source control and we're looking for ways to try to damp this down, then yes, we'll go to an MRI, we're going to find all the infected areas, and the person's going to go to the OR and probably lose a significant portion of or all of their foot. But that's not what, that's not this particular case. But good questions, really good questions.
Great, thank you so much. I think that's all that's, unless I missed anything, all that's sitting in the chat right now.
Great, okay. Case 3. We have a 52-year-old female came back for a follow-up visit, an acute visit. 50-year-old female with unilateral swelling of the foot and lower leg. She has diabetes, hypertension, and some mild chronic renal insufficiency. What do we do with a red, hot, swollen foot? This is a fun one. What is our differential diagnosis? I want people to think about that for just a minute, for unilateral swelling. I tend to think about it as infectious or non-infectious. That's how I tend to break it down. When you have a red hot swollen foot, infection absolutely should be at the top of your list. We want to evaluate for infection because that would need immediate attention. But I want you to also think about the non-infection causes of a red hot swollen foot. Infection could be cellulitis, septic arthritis, osteomyelitis. Non-infection causes can be a DVT, which we would use our vascular colleagues, the vascular lab, to do a Doppler to look for a DVT. Inflammatory arthropathy, so you think about the crystal or non-crystal. Neuroarthropathy, such as the dreaded Charcot foot. OA can show up as unilateral redness and swelling if they overdid it. And complex regional pain syndrome can also present that way. In a Charcot foot, frequently, it will show up as unilateral. It will be red. It will be warm. It will be edematous. So a lot of people go down the DVT pathway. They go down the cellulitis pathway. If patients are admitted for lower extremity cellulitis, they're put on bed rest, they're given IV antibiotics, and they magically start responding. We will often attribute that to the IV antibiotics, where if it was an underlying neuroarthropathy, they were responding to the bed rest. So they stopped using the injured part. So who's at risk? So the literature says between 0.3 to 12% of diabetic patients with neuropathy are at risk of developing a Charcot foot. So the incidence, if we go with that higher number of 12%, there's going to be some people that we're thinking have cellulitis where they actually may have a neuroarthropathy. And then how does it develop? You get this exaggerated response to trauma. And trauma is a really misleading word there, because it could be something as simple as missing the step and coming down hard on the foot, stepping wrong off the curb, having family come to visit and they did a walking tour of Pike Place Market and they walked a lot more than usual. So trauma is not a car accident. It's not a fall off of a ladder. It can be something very, very subtle and something that we wouldn't think would cause an injury. But because of the underlying neuropathy, it was enough to cause an injured part. And when there's dense peripheral neuropathy, we'll often get that autonomic overlap, which will have a vasomotor instability. And that's what's felt to be one of the drivers of the actual Charcot process, is that vasomotor instability, that exaggerated inflammatory response. A little bit of a busy slide, but just the salient points is that when you have diabetes with neuropathy, vasculopathy, metabolically abnormal bone, you get a trauma, which causes inflammation, bone resorption, stress fractures, deformity, abnormal weight bearing, ulceration effect. So the abnormal weight bearing then causes additional trauma, which you just stay in this loop. The part doesn't feel right, but they don't realize they're actually walking on fractured bone. So they keep using the part, which turns the trauma inflammatory response back on. So they just don't get out of that loop. Relatively normal looking foot. A little bit of arthritis here in the midfoot. This is going to be our heel bone, our calcaneus, our talus. This is the navicular. This is the medial cuneiform. This is our cuboid. Bones are kind of happy. They kind of align with each other. If we look at the X-ray of a Charcot foot, we see it looks quite different. The head of the talus, if we bisect the neck and the head of the talus, it's no longer parallel with the bisection of the first metatarsal bone. There's a collapse between the navicular's collapse. The first cuneiform is overriding the dorsal aspect of the navicular. Part of the navicular and the cuboid are trying to extrude out the bottom of the foot. The X-ray even shows some lucency in the soft tissue, which correlates quite well with the bones that are trying to extrude out the bottom of the foot and have ulcerated the skin. So you don't have to be a radiologist to kind of appreciate that this is an abnormal film. But this was somebody who had just a foot sprain from, nothing big, nothing dramatic, and then got a swollen foot. And, because they're trying to walk on it, they're trying to walk to manage their diabetes and lose a little weight and keep their heart and kidneys healthy and do all the things they were told to do. They just kind of kept trucking along, with the foot getting more swollen and more misshapen, and now they come in with an ulceration and a collapsed foot. So this is a full-blown Charcot foot. Charcot is stage, so early inflammatory, you're going to have a lot of edema, but you're not going to have X-ray changes. The foot is not yet collapsed. So this one, that early stage 0 is really difficult to differentiate from cellulitis or DVT, except that they're going to have a negative Doppler and they're not going to have inflammatory markers elevated or a white count unless that's from another cause. In the developmental stage, you're going to have the edema. You're going to start to see some X-ray changes. If we can capture people in 0 or 1, we can try to stabilize the foot so they don't get a full-on collapse and fragmenting of all the bones. During stage 2, you get some coalescence, the edema starts to wane, and you start to see fracture healing. You see some bony callus forming around the bone. And then you have the remodeling where the edema is resolved and you have a lot of bony callus where the bones have collapsed. So our goal is to try to identify zeros and stage 0s and 1s so that we don't have a collapse of the foot, because once the neuropathic foot is collapsed, it's very, very easy for the skin to ulcerate because the people don't feel that they're getting a pressure point due to the abnormal weight bearing from the collapsed bones. Treatment for Charcot is to offload, and this is why they do so well when they're admitted for cellulitis and they're put on bed rest to have their IV antibiotics. That is the main treatment for Charcot. And when you unload a Charcot foot, the redness and swelling will start to improve dramatically, usually within 24 to 48 hours. We use redness and swelling as a marker for when people are starting to return to activity following treatment of their Charcot foot, and if they start to get redness or swelling, they have to back off their activity level. We use a cam boot. That's one of those removable cast boots that Velcros on, crutches, knee scooter. I'm a little jealous at the VA. They can get a knee scooter in real time, so we can't. It's a bit of a challenge to get those. We've even put people in wheelchairs. If we have whatever it takes to offload, if someone with an autonomic neuropathy, trying to have them ambulate in with crutches on one foot. We're asking them to fall. So, we'll go to a wheelchair if we have to. You want to protect the skin from breakdown. Insensate skin protections, really examine frequently, and protect the foot from collapse. The Charcot Restraint Orthotic Walker is a custom-made Herman Munster type boot that people wear instead of a cast. So you can do a total contact cast, but that's very challenging. The Crow boot, and I'll have a picture of that, is something nice because people can do daily skin care and they can do frequent skin inspections. Eventually, patients will progress to diabetic footwear, but that can be months down the road. It can be 3 months, 6 months, 12 months, whatever it takes to get the foot to no longer be red and warm to touch. So this is a cam boot. This is sort of universal fitting, comes small, medium, large, extra large. Left and right it's ambidextrous. It Velcros in place. There's an air bladder here that you can help snug up the fit. You have to watch that they don't rub on the malleolus or rub along one of the metatarsal heads and cause a skin ulcer, because then you have two problems to treat. But this is a good first device. You can put it on that in real time, usually during that clinic visit or within the next day, and help protect that foot from collapsing. It allows people to do frequent skin inspections, allow them to take a shower. Initially, I tell them to wear it to bed, and then as soon as the foot starts to be not so red hot or swollen, they can take it off for sleeping. But I really want them to treat it like a cast, except they can do skin care in the early stages. The knee scooter is lovely. I have seen people that took the knee scooter as a license to keep their normal active lifestyle and develop a Charcot foot on the contralateral limb. So I do say this is not to allow you to do everything. This is just to allow you to safely do some things. This is the Crow brace, the Charcot Restraint Orthotic Walker. This is a custom-made boot. It has a rocker sole with a tread. It has a liner that can be refit as the swelling is reduced. This is a very misshapen foot that would not fit into the pre-made device very well. It would be at risk of developing skin breakdown. So these boots are made individually to people. It's like a clamshell. So there's a front portion and then the back, the bottom and the back, and that Velcros into place. This acts like a total contact cast. It does help to stabilize the foot, prevent further collapse, and it does help reduce some of the edema. So that's why the liner is able to be adjusted, is as the edema goes down, they need to refit the lining on the inside. And people will eventually graduate to diabetic footwear if possible. I have had some individuals that have had to stay in a Crow brace for ambulatory activities. These are people that are not high distance ambulators at baseline. They developed a Charcot foot or ankle. We use the Crow brace to support them when they are going to do some limited ambulation, and then they can use the diabetic shoe if they're just going to be in their motorized wheelchair or scooter for the remainder of the day. So if we can catch a Charcot foot early enough and there's not significant deformity and the person was a pretty reasonable ambulatory activity before their episode, then frequently we can graduate them out of the Crow brace and into prescriptive footwear. These are folks that will need close follow-up long-term because the Charcot can be reactivated at any time. Anytime they overdo something, it can be reactivated. We teach patients to check the temperature on their foot, to check for redness and swelling every day, and that can dictate how much weight-bearing activity they can do on any particular day. So this is something they will live with the rest of their lives. Questions?
It looks like one question has come up. How long do patients remain in cam boot or the Crow brace for Charcot foot?
Until the foot is no longer red, warm, or swollen, and the x-rays show consolidation of the fractures. So that can be as little as 3 months. It could be as long as 12 months. So the more the patients offload their foot, the faster the bones will consolidate. And so I really tell them that some of this is up to them. The more that they say, well, I'm in the brace, I can still go do these errands, then it's just going to take longer. They'll be in the brace longer. Good questions. Let's talk toenails. Okay, 28-year-old type 1 comes in with an ingrown toenail. Several days of increasing pain and swelling. A1C is pretty reasonable. Creatinine's fine. This is what they have. So there's a couple of hints here. This is warm to the touch, tender, because he still has intact sensation. Little hint of some drainage along the one side at the skin fold where the nail edge meets. A little bit of shaggy toenails. So I'm a little bit suspicious that perhaps the nail trimming was a little off schedule. The patient got busy, let the nails get a little bit long, then toenails got retrograde pressure from the socks or perhaps hit the end of the shoe and caused a break in the skin, allowing bacteria to get in. This is actually a paronychia. This is, inflammation with some infection of the skin folds surrounding the toenail. Aside from, the nail care being less than optimal, there's not really deformity on this toenail. So I think there was a mechanical issue between nail, shoe, skin, causing a mild skin break, allowing bacteria to get in. So this would be this is an ingrown toenail, but it'd be more like a paronychia, and it would be treated like a paronychia. So this one needs antibiotic. This would either you could use cephalexin or you could use doxy. Instruct the patient to soak the toe about 5 minutes, and I tell people 5 minutes, not 30 minutes. 30 minutes of soaking is going to strip all the natural oils out of the skin and cause the skin to get dry and cracked, which will cause a second problem. So I tell people set a timer. They're going to use warm water from the tap, check it with their hands, so don't cause a scald injury. About 2 tablespoons of Epsom salts per quart of lukewarm water. Soak it 5 minutes, set a timer so they don't get distracted, and keep that toenail trimmed straight across. So this one does not need to be surgically excised. This one does not need to have a portion of the nail plate removed. This was, just a retrograde pressure, a little skin injury. This will respond to antibiotics. But what if the patient comes in and the toenail looks like this? This too is an ingrown toenail. There's a couple of hints here. There is some discoloration at the tip of the nail that's saying there's either been some chronic pressure going on and is causing some onycholysis where the toenail is being lifted up. This could represent some onychomycosis where some fungus is tracking back under that toenail, causing the toenail to lift up. But the big clinical hint here is the granuloma on the medial skin fold. The body will make a granuloma if the nail has punched a hole in the skin and the nail is sitting there and not allowing the skin to close the hole. So the skin will do whatever it takes to try to close the hole. It'll just make more skin and more skin and more skin. So when you see a granuloma, just giving this patient an antibiotic is not going to solve the problem. That's a little bit different than the prior, where we just had a little bit of drainage and a little bit of puffiness, but there was no granuloma here. So this nail does not need to be excised, either partially or totally. This nail's going to need a little bit of help in order to get well. So when there's a granuloma, we need to do something about that. Yeah, the lateral skin fold's a little bit irritated and a little drainage, but this is the one that this will not get well until we take away at least a portion of that toenail. Now, if there's a lot of risk factors, I will have a lower tolerance for adding an antibiotic. But say this was one of your patients that didn't have diabetes. Say they didn't have other medical comorbidities and they came in with this. They wouldn't necessarily need an antibiotic in that situation, but they do need to have part of the toenail taken away in order for this to be resolved. So the antibiotic in this situation, the antibiotic, yes or no, is going to be driven more by the medical comorbidities that exist in the patient rather than the clinical problem. Excision of the toenail is what's going to solve this. They can do the soaking with the Epsom salts and set the timer and all that, but that's still not going to solve this problem. So this toenail, either all of it or a portion of it, needs to be taken out so that the hole in the skin can heal, and the granuloma will shrink on its own. If you really want to, when you're taking out part of the toenail plate, you can excise the granuloma, which will bleed a lot because there's a lot of new tissue growth there, and all that angiogenesis. That will need to be treated with silver nitrate. You can excise a portion of the toenail and just use silver nitrate on the granuloma, which will help it shrink down a little faster. But just purely getting enough nail out of the way, the granuloma will resolve on its own. What if this was what was billed as an ingrown toenail? I don't see much in the way of erythema. I don't see exudate. I do see an abnormal nail. And this one is giving me a lot of hints that it possibly could be some onychomycosis. 95% of onychomycosis is going to be distal subungual, meaning it's going to start at the tip of the nail and it's going to track back underneath the nail plate. If I were looking for evidence of onychomycosis by taking a sample of the toenail, it's easy to trim some of this distal part of the nail, but there's a chance that you're going to miss whatever is tracking underneath the nail. When you take the distal aspect, it's easier to grab, but the dermatophyte could be burned out by then. So your higher yield is going to be removing as much of the damaged nail plate as you can and sampling from the proximal leading edge, because that's going to be a higher yield, more accurate sample. So antibiotics are not indicated in this situation. Neither is soaking. Soaking's not going to change this. You want to keep the toenail trimmed straight across, or consider a total nail avulsion. Just take away the bad nail and let them grow a new one. Or if you want to entertain the role of an oral antifungal, if there's not contraindications because of either some med-med interactions or some other issues, I would want to know that I could culture a fungus from this nail before I would go the oral route. I do, when I am sampling, I would trim back probably this far and then start taking my sample from this zone. And I would send it for both a KOH and a fungal culture. The fungus can be a little bit bashful trying to grow it in the lab. I don't have a negative culture until it's been in the lab for at least 4 weeks. So I'll see the patient back at the 5-week mark to review the lab result. If you get a positive KOH, they see some hyphal elements or some budding yeast on the KOH, but they just can't coax growth out of it in the culture medium, I would still consider that a positive result and consider treating this with an oral antifungal if it was appropriate. I am reluctant to really use a lot of oral antifungals in absence of some lab data to back it up, only because this could just be some nail changes from other causes. There's lots of causes of nail changes. And what's disappointing is you say, oh, this has to be fungus. You treat it and the nail doesn't change. And now you don't know what you were originally treating. So this has been going on for a while when this much nail is involved. There's no acute infection, so there's no urgency. If the patient really wants to try to go with the oral route, take your samples, get your lab data, see them back in 5 weeks, and discuss the next best choice. What if someone's billed as having an ingrown toenail and this is what they bring you? So again, although the background coloration of the skin can be a little bit trickier to look at, I still don't see any erythema. I don't see any exudate, but I do see some toenails that look uncomfortable. So this is onychocryptosis. This is malformation of the toenail. And this can be from some fibrous growth that happens under the nail bed that causes the nail plate to become deformed. You can see it on several of the toenails. This can be a family trait. This can be from trauma. This can be, there are some medications that can cause the toenails to grow like this. Antibiotics are not indicated. There's really no bacterial infection to treat with an antibiotic. Soaking will not change this. You want to trim the toenail straight across. You can thin some of the deformity of that nail plate with an emery board. Just that will take away some of the pressure along the skin folds, which is what the patient's experiencing is there's a lot of pinching of the skin folds. You can remove the toenail. But this does not need antibiotics. This does not need soaking. Although patients will come in all the time and say, I have ingrown toenails. And it's like, well, yes and no. What if this is what the patient shows you when their build is having an ingrown toenail? This is just a toenail out of control. So this is onychogryphosis. This is a ram's horn toenail. This is somebody that needs a little bit of TLC, some dead adherent skin. I'm going to guess there's some stuff going on between the, in the interspaces there between the toes. This just needs a good soaking, not at home in your office, and get the toenail trimmed back. So these are actually quite gratifying to do because within minutes, the problem's solved. No antibiotic needed. That's your friend for taking care of a lot of these problems. And don't underestimate the role of an emery board. It can definitely help in some of the situations. They can thin the toenail, so they can take the emery board. Let's go back and look at one of these pictures. They can take the emery board, particularly on this big toenail, and they can just sand that all down, and so that nail is much flatter. And that alone will start to take away some of the pressure along the corners of the toenail. Same here. They can thin that center part that's all humped up, and that starts taking away some of the pressure. What you don't want to do is you don't want to start cutting back these corners because that will allow the skin to pooch up in the way. There's nothing holding the skin down. And the toenail only does one thing. It grows from the root towards the tip of the toe. And if the skin is sticking up in the way, the edge of that nail will definitely get trapped in the skin. And then they could make an ingrown toenail and develop a granuloma, but that would be sort of an iatrogenic problem. So, okay. Questions about when do you want to think about an antibiotic for an ingrown toenail versus just some mechanical treatment like trimming the nail back?
There's one question that came up in the chat. Do you find that the oral antifungals are worth it in terms of efficacy and potential side effects?
Great question about the role of oral antifungals. The higher the risk of secondary bacterial infections such as lower extremity cellulitis from a deformed fungal nail, the quicker I will entertain the prospect of using the oral antifungals, because doing careful lab monitoring, maybe temporarily adjusting the medication profile, maybe holding the statin for a few weeks, is very worth it if somebody is at risk of having a lower extremity cellulitis requiring hospitalization because they had a deformed fungal toenail. Patients that have had a lower extremity cellulitis requiring hospitalization and it's determined that it was due to untreated tinea pedis and onychomycosis, then yes, we will definitely try to get those toenails as cleaned up as possible. But I do start with a culture. I just need some data in front of me saying this is from fungus. I have a lot of patients that come in and they don't like the appearance of their toenails. They're on some important medications that would be affected by the addition of an oral antifungal. And we talk about conservative management of their feet without going the oral route. But there are some times where I'll push to try to get the oral antifungal treated, and that's particularly people that have already proven they can get a secondary soft tissue skin infection. So, good questions today. Okay, so I'm not sure how we're doing on time. What we have?
We've got another 5 or 10 minutes. So.
I ran out of material. How did that happen?
That's okay. That was actually perfectly timed.
Okay.
In case there are any other questions that come up, please feel free, people, to turn on your cameras or unmute yourselves to ask questions as well.
Now's your chance.
Katrina, just generically, do you have any guidance to this group about who should be referred to you? Who are people that you would love to see? Who are people that you think don't need to be referred to you?
So that's a great question. I wish I had unlimited appointment slots available. When you have a patient with a diabetic foot ulcer, I would love to be involved to try to help guide that wound towards closure and to try to engage the patient in ongoing care so that the wound doesn't come back. That would be ideal. If you have a patient with a really bad ram's horn tornil that you or the nurses are uncomfortable trimming, those are fantastic. We get those taken in a one-time visit, and then we identify who can help keep the patient's toenails under control. If you have a patient with a Charcot foot, please offload them. I'm absolutely happy to help guide their care towards consolidation, and then try to support them in preventing further Charcot deformity on their feet, and hopefully prevent skin breakdown. If you have a diabetic patient with significant foot deformity and you feel the patient is at risk, I would love to help co-manage that patient with you. I would on things like diabetic foot screening. I think that we are trying to support our internal medicine residents at feeling comfortable doing their own diabetic foot screening exams and maintaining that part. If you have a patient that just has some unruly toenails, they're not significantly deformed, they have diabetes, our nurses are very well trained at just doing some of that maintenance work for us. So I would encourage you to consider setting them up for some nurse foot care. Some of the different clinic sites have varying ability to also support that. If you have a patient with, sort of an unexplained sprain, strain, foot issue that you feel like you're not getting good progress on resolving, I would be glad to try to help sort that out with you. You have a patient with pretty significant bunion deformity. They don't have comorbidities that would make them a poor surgical candidate. Those can go straight to the Foot and Ankle Institute, because if the patient comes to me, that's where I'm going to send the patient for surgical consideration or consultation. If you have a patient with medical comorbidities that would make them a poor surgical candidate, I can try to work with that patient to keep their feet out of trouble while we either help solidify their medical care so they can become a better surgical candidate. But if it's a straightforward patient that just is ready to have their bunion fixed, this can go straight to the Foot and Ankle Institute. They do a great job with that. So hopefully that clarifies a little bit of some of the folks I would love to see along with you.
Is there any role for topical corticosteroids in the setting of an ingrown toenail to reduce inflammation related to soaking?
Oh, that's a great question. I have not seen that help that much. So the topical corticosteroids, when the skin is inflamed along the edge of an ingrown toenail, I just haven't seen it do much. And a lot of times if there's an ingrown toenail, particularly with something like a granuloma, there's going to be a little bit of bacterial load involved. And so I'm not a big fan of putting topical steroids in potential bacterial infection sites. So I've not seen it help much. So it's interesting, the salt soaks. It's the water helps, but it's actually the salt. The salt will have a different chemical charge than the very protein-laden exudate, and so it actually draws the exudate out. It's kind of using old chemistry before we had modern antibiotics. So that's why the salt works really well. Just like a poultice is very drawing because you're taking advantage of the positive and negative charges of different items. So the salt soaks are they're pretty miraculous. They can really help drain some pus from the edge of a nail if people actually take the time to do it. So yeah, what's old is new. Well, thanks everybody for your time and attention. Figure out how to do this. Thanks very much.
Thank you so much for being here. I think we all learned a lot. So really appreciate having you here today. And then for everybody else, so Ken was scheduled to do a house staff meeting later this morning. However, some of you might know that Ken is on service right now in the UMICU, and I think all good intentions to join us this morning for academic half day. As things happen in the ICU, they get really busy. And so Ken is unfortunately going to be unable to join us today, and I think he is really sad about that he's going to be missing, and wanted me to communicate that to each of you. He is hoping to have a Zoom meeting for a house staff meeting sometime at a later date, potentially an afternoon meeting that he will send out and try to schedule with everybody. It works with different people's schedules, maybe sometime later this week or next week whenever he is off service. If there are certain things, concerns that you guys have that you would like myself or John to sort of float up that you might want Ken to address, please feel free to use me as a channel for that. But otherwise, everyone has an extra sort of hour and a half this morning to do whatever you are doing currently or catch up on something that you need to catch up on. I'll hang out here for a little while if anyone else has other questions, but thanks for joining us this morning.